This is QD Clinic, and I'm Jack Cush with Room Now. QD Clinic is brought to us by PsA All the Way, our campaign on psoriatic arthritis. This week, check out some exciting blogs on PsA. Eric Ruderman's got a good one about co-management. He runs a Room Derm clinic on psoriatic arthritis. And Rachel Tate's got an interesting one on MDA, that superlative goal of minimal disease activity. Today, my case is getting as good as it gets. I've got a 55-year-old patient with psoriatic arthritis. She's had psoriasis going back to like 1978, something like that. She developed psoriatic arthritis almost 13, 14 years later in 1991. Then the diagnosis was established based on symmetric oligoarthritis, a bout of dactylitis, an occasional elevated SED rate of 50 or 67, and seronegativity. She had fairly minimal arthritis, managed with nonsteroidals, 1 point nonsteroidals. She didn't want to take methotrexate because she was young and she wanted to drink wine on the weekends. And I didn't get her until the late 90s, and it wasn't until around 2005 that I started her on etanercept. And not surprisingly, she did remarkably well. In fact, she went into remission. She had more arthritis than skin disease at all times. She had some activity occasionally behind the ears, in the scalp, belly button, but not like a tremendous amount of skin. And as long as she was not on a DMARD or a biologic, that was always there, but not a major problem. As soon as she went on etanercept, all her skin problem went away. But so did her arthritis. She rarely ever had any problems. So you can fast forward from 2005 all the way up to 2021 and even 2022, and she's still in remission and still on etanercept. So there's several things that I think bear an underline here in the story. Lesson number one, a line that you should tell all your patients who are on methotrexate, who are on etanercept, who are on any kind of long-term therapy. And I think it's very important to say this, and that is, the longer you take the drug, the safer it is. Because if you don't say it and you don't believe it, then they're going to worry. If you don't say it, they're going to think, oh man, I shouldn't be taking this stuff. It's poison, it's toxic, it's building up in my system, it's changing all my good humors to evil humors and whatnot. And again, they're reminded not by you, they're reminded by television ads that say ugly things that biologics can do. But the fact is that if you go on a TNF inhibitor or on methotrexate, you're going to have problems with it. It's going to be early on. It's going to be first 6 months. After that, it's a random event. It's not the cumulative exposure to etanercept. The risk of TB is very, very early, right? The risk of bizarro things, LFTs, for instance, always early, not going to happen in year 14. So the longer you use the drug, the safer it is, not the more dangerous it is. Second, over the years, she's had musculoskeletal problems. And the question always is this her arthritis and or enthesitis coming back? She's young, she's athletic, she plays sports, she runs, she goes to gyms. You know, she's had tailbone pain, shoulder problems, heel problems. And the question always is this a sports injury or is this enthesitis? Almost always that can be resolved by a good history, physical, and sometimes imaging and sometimes labs. But more often than not, these were intercurrent problems based on activity. And time and a little TLC was going to prove that. You do have to worry that they could have an enthesitis or a flare-up of their arthritis, especially if they're not without your knowledge or consent, weaning the medicine, taking less of it. She was not doing that. And in every case, she's never really had enthesitis or anything that we needed to change her TNF inhibitor for or increase the dose. The third thing worth underscoring here is comorbidity management. She's young, she's healthy, she's not obese, she's athletic, she's slim. She has no depression, but she has had hypertension. And I think it's my responsibility as her rheumatologist and the person who knows about the risk of comorbidities with psoriatic disease that I make sure that she gets normal screening things done, like lipid levels once a year, a hemoglobin A1C once a year, seeing a cardiologist once she turned 50, and telling her she doesn't need to go every year, maybe every other year. Her mother has a history and her father has a history of cardiac events, but she certainly has no other risk factors other than her hypertension and her psoriatic arthritis. And then lastly, what about the TB risk? She was tested for TB with a skin test way back when we started, and then has had a quantiferon. Do you have to repeat that annually? No. No, 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 no. And if insurance companies tell you to do that, they're a bunch of idiots. The risk of TB does not go up with prolonged TNF inhibitor use. It does not change annually. It only changes when her risk changes based on her exposure. So if she's been around someone with active TB, if she traveled to Calcutta and was working in the slums where there's a high risk of endemic TB, then yeah, she should be tested. But there's no reason to do repeat TB testing. Again, when the going gets good, that's all you need to know, and that's what you need to remind the patient of over time. Tune in for more QD Clinics.